All right, we're gonna go ahead and get started. I'll apologize up front. Our television is up here, and you guys over here, it's kind of hard to see. Left the mineral wells office to get over here, and unfortunately left my projector that normally got this nice big screen over here so that you can see very well. So best you can, we'll try to make do with what's going on up here. So we're here for the 2-hour talk about low back pain and sciatica. Everybody ready?
No.
No? Okay, maybe not 2 hours, but no. Rotator cuff, shoulder pain. I will actually start and get straight into this. So one of the very first things, who's had shoulder pain in the last 30 days? I raise my hand because I'm also a member of the Shoulder Pain Club. And that's part of what I deal with on mine. And we'll talk about mine in a little bit. I don't have all my technology squared away. No, let me go back. I'm doing this wrong. You rely on technology and then it goes bad on you. So in the past 30 days, we've all had some shoulder pain. The important thing to know about having shoulder pain is what were you doing when you had it and how bad was it? So we're going to talk about that as we move forward. Mine is mainly if I do a lot of work overhead or if I sleep wrong. I'm a bad sleeper and I sleep like this, which we shouldn't. So that's usually what irritates mine. Over the last 30 days, my shoulder's actually been quite kind to me. My pain, in the medical world, we use the 0 to 10 pain scale. 0 is no pain, 10 is your worst imaginable. The last 30 days, probably 2 out of 10 is the worst mine's been. I'm very happy about that. And again, I can identify what I do by, when I sleep or if I'm doing a lot of heavy work overhead. So think about what you've been doing, if you can identify the activity that brings yours on. So a little bit about me. My name is Luke Haynes, and how did I come to specialize shoulder and rotator cuff treatment? Well, we'll talk about my education and experience and so forth, but really mine started because of high school football. So I've been at this for a little while. Senior year in high school, I'm in one play playing defense. I go to make a tackle. Somebody lands on my shoulder, it dislocates. Take me out of play, put it back in. I go back in the very next play. Same thing happens on the other shoulder. So I'm 17, so we rub some dirt on it, we move on. It's no big deal. 20 years down the road, then all of a sudden, I'm trying to pitch to my young kid and teach him how to pitch. And all of a sudden, this thing is just jelly. I can't do anything. I can't throw from here to my laptop. And so, now at that point, I was also a physical therapist, but I didn't know as much about the shoulder at that point as I should have. So what did I do? I went and had surgery on it. 3 weeks after surgery, I go out and I play a round of golf and I blow it right back out again. So since that time, I've not had more surgery on it. I do have more tears. I have some torn cartilage in the labrum. We have, I had a bone spur that should be gone now. But I also know I've got some stuff over here. So over the years since then, where I really learned what I know, not just my education, not just my experience with thousands of shoulders, but it's by keeping mine under control because I didn't want to have surgery again. So that's where my part came in. So my education, again, I've been at this for a little while. I graduated from Texas Tech in 1994. Back then, we graduated, I was the last year they graduated with a bachelor's degree. They moved on, they started giving out the master's degree, and now everybody gets the doctorate degree. So I'll bring other physical therapists up in a minute. Kat, she's fantastic, you'll enjoy her. I had to go back to school to get my doctorate degree. I learned a lot in it, but quite honestly, the truth be told, part of the reason I wanted to get it is so that when I had young 20-year-olds coming in with their doctorate degree, I didn't have to be the guy that didn't have one. So, but I did learn a lot getting that. That I got through the MGH Institute in Boston. And since then, a lot of the things, and we'll talk about this a little bit, I've got now triply certified in what we call dry needling. What is dry needling? It's a Western medicine version of acupuncture. I use the procedure extensively for dealing with pain, joint inflammation. It is one of the main reasons why my shoulders stay in good shape. So I developed and copyrighted my own version, and I teach. Well, I had an online seminar today of about 80 different clinicians across, well, the U.S. There are some from Canada, some from Europe. So we teach this as part of a professional training series as well. From time to time, I will lecture collegiately. And as far as clinical experience, these numbers are probably a little behind, but I probably treated or supervised the treatment of over 500,000 patient treatments, and dry needling over 30,000. Again, these are a little behind, probably 150,000 plus needles. So, but before I get too much further, I know some folks had some issues about the time. At the end of this, I'm going to offer, if anybody wants it, to come in and me or Kat or Liz will do a free screen of your shoulder and what's going on. So if you have to get up and depart early, I've got people over here who will take care of you, to take care of that. So before I ran out of time, I wanted to get to that. All right. Also, I tend to talk really fast, so if you have questions, spit it out, yell. My whole goal is to get some information to you about the shoulder, the rotator cuff, what sort of problems can happen, what sort of things can be done for it. All right. So what is the rotator cuff? So we're going to talk about the rotator cuff here. I'm going to introduce Dr. Kat Watson. Let her come up and take it from there.
Hey guys, I'm Kat. You may have met some of you. I just click forward.
Yeah, just click.
Cool. Okay, so I'm going to try to keep this as simple as possible. In general, the shoulder joint is actually really, really complex as far as everything that goes into the movement. But we'll just kind of narrow it down to the main points. Okay, so first of all, the bones here. So you've got a couple things going on. So this is the humerus, basically your upper arm bone. Over here you have your scapula, which is your shoulder blade, and then your clavicle or your collarbone. So all three of these kind of work in conjunction to produce the shoulder movement. So it's not really just considering one or the other. Everything has to kind of work together, or you might start getting some limitation. So yeah, I've got three bones. Oh, look at that. I had the answers and I didn't use them. I guessed right. Perfect. Oh, acromion. So we labeled the other piece there. How do you go back? Technology's hard.
Well, especially when it's the wrong technology.
Yeah, you know, we tried.
10-year-old, they know it all.
I can text, that's about it. Oh, I didn't even. Okay. Cool. Okay,
We're
figuring that
normally
out.
much more organized than this.
Yeah, normally it's less than this. But yeah, that little piece there, the acromion, is basically just labeling part of that shoulder blade that sticks out, and you'll see where that's important, especially with things like, you might have heard the term impingement before. So whenever that arm bone comes up, usually it's that humerus right there butting up on the acromion. So that's where you kind of get that pinch, if that makes any sense. But we'll kind of keep moving here. Okay, so what is the rotator cuff? Moving on. Okay, so the joint itself, so highlighted in green, I'm not sure if you can see it or not, but that's looking at the head of the humerus. So this is known as a ball and socket joint. You can kind of compare it to, I think we have a picture. Oh, look at that, ball, socket, right again. Yeah, but if you want to think of an analogy for the joint, you can think of a golf ball sitting on a tee. So the shoulder joint is cool because you have tons of mobility, but the sacrifice is that there is less stability regarding the actual joint surfaces. So it's that head of the humerus just sitting on that small surface. So that's why you can move it so much, but why it can also be unstable if the muscles around it aren't working as they should be. So that's the joint. Let's keep on going. Okay, so the rotator cuff, that's the muscles themselves. So here we have some pretty little pictures where it'll probably pop up the names in a second. Okay. Is there any way to get like my arrow on there? Or?
just roll the mouse forward, and it should jump up.
No. I'm using this rolly thing, or do you mean like this?
There we go. Just kind of
Whoa, that's
bump her
cool.
up right there.
Sweet, okay. So that right there is the supraspinatus. We're looking at 4 muscles total. You can say it wherever you'd like. So that's the one that's most commonly implicated and damaged, I would say, as far as getting impinged and pinched on in that little area that we talked about earlier. So there's one, that's the smallest guy sitting up top. And so just for reference as well, you can probably tell, but here on the left side, that's looking at the back of the shoulder. So you can see that guy there, and then below that you have your infraspinatus. Below that you have your teres minor. You probably don't hear about that one as much. Usually whenever you get some imaging back or someone says, oh yeah, I have a rotator cuff tear, it's almost always something having to do with this one and maybe combined with that one. That one you might not hear as much about it. And then over on this side, we're looking at the front of someone's shoulder. So you can see that this muscle kind of sits right on the front surface of your shoulder blade and comes across to attach. Yeah, so basically it's called your rotator cuff just because you have all 4 of these guys on the scapula and they come across to insert on the head of that humerus. So it kind of creates a cuff around that joint. And the main functions of these ones in particular are rotation, hence the rotator cuff. So there you go. So 4 muscles total. And then, is this one a moving animation or?
No. The words will pop up.
Great, okay. Okay, so this is basically just talking about how, similarly to the muscles, you need several things working in conjunction with each other in order for this joint to work properly. So you can't just consider the shoulder itself. You also typically need to look up at the neck. So whenever I have someone coming in with shoulder issues, I'm going to screen the neck and I'm going to look at their upper thoracic as well, which is just below the neck, because sometimes you may have some issues, in the shoulder joint itself, but there's almost always one of the other ones that are also just contributing. So typically it's not alone and you have to consider these. There's actually a pattern of movement with the shoulder blade. So you're not just considering this arm bone kind of lifting up, you're also getting a relative rotation of this entire shoulder blade that's kind of having to shift up as well. Typically that first 30 degrees, it is going to be mostly just this joint, but after that, there's kind of a 2-to-1 ratio of this entire unit having to rotate. So as you can imagine, if you have limitations with the scapula or where it's connecting right there with that collarbone, that's going to limit your overall motion. So basically it's a little complicated, but you've got a lot of pieces working together just for this. Doesn't seem like it, but pretty complicated. Oh, there's another thing too. We're pointing out the rib cage because another thing to consider here is the first rib and actually the first few. If you have any issues with your ribs as well, that can also limit your shoulder motion. So, okay. Does everyone have the papers? So nobody's grading this. You don't actually have to fill this out, but if you would like to, you can. So as you can see here, the rotator cuff, like we talked about, it's a group of 4 muscles that move the shoulder. As far as the type of joint, as you can see right there, it's a ball and socket. There are several types. That's just kind of how they classify them based on how they articulate together. And then, also like we just discussed, there are 4 areas that work together in order for you to have successful shoulder movement. So you've got to have the neck, the collarbone, the shoulder blade, and your rib cage, all kind of working together.
I'll see you back in a minute.
Okay. Just casually put this on upside down.
All right. So I want to talk about the whole goal here. We want to get back to normal. We want to get this thing moving, get the function, the movement, the strength, everything back in the shoulder that we can. So what we're interested in is, can we reproduce this pain? At the very beginning I said we want to identify what it is that's happening whenever you get this pain. And so one of the things as a clinician is I want to reproduce that. Can we reproduce that and get some consistency with what's causing the discomfort? If we can, good odds that we can make a difference. So I want to back up a little bit to you know, I mentioned 20 years after I injured my shoulder, then I was a physical therapist, and I was doing what I learned in school. We come out of school, we think we're super smart, we just haven't seen a lunch yet. And so back when I injured mine, I was still doing my stuff the same old way that I was taught. Nothing wrong with it, it gets the job done. But when we look at the numbers of what, as a therapist, what I was seeing with my shoulder patients, 50% of the folks who would come in for shoulder therapy, they were doing fine, they were getting some strength, they were getting some exercise, pain was still there, and at the end of the day, they felt like it helped a little bit. They're still dealing with that nagging problem and probably didn't have the tools they needed to take care of it from here on down the road. 25% of the folks did fantastic. There was an issue, we did our therapy stuff, and they were great. And then a full 25 other percent, it was horrible, because shoulders are so complex. So they probably ended up having to have surgery, similar to what I did with mine. And so traditional physical therapy, this just really not the best numbers out there. And I'm gonna be honest, most clinicians still today are in this same boat because of my experience with dealing with both of my own shoulders and the work on my doctorate degree, the work on creating all of my content for my dry needling series. I changed the way that I looked at the shoulder. And so Kat just talked about these 4 sections. Well, back in the day, if you had a shoulder problem, well, we just came out here and we looked at the shoulder, and that's all we dealt with. Well, we now know that the neck, the rib cage, the shoulder blade, and the collarbone, all of them can have a role on that. So we have to look at all of those pieces. And so once we start looking at that at a larger picture, now all of a sudden, using all 4 of those systems, 90% of the people that I see with shoulder problems, we can help. I'm not gonna say pain-free, I'm not pain-free. At 50 plus, I wake up, I don't anticipate being pain-free, but I'm minimal pain and I can do anything that I want to. So 9 out of 10 people, we can help. There's still, I don't know how many people are in here, 1 out of 10 of the folks in here, if you've got serious shoulder issues going on, pain's above, say a 5, 1 out of 10 is gonna have surgery. Tearing and limitations are significant enough that there's not much that we can do to bring that inflammation, that pain down. Which, let's be honest, we're here, number 1, because of pain and loss of function. That's the 2 things. Sometimes we can deal with the loss of function if we're not dealing with pain, or if we've got some pain but we're still doing our work, we're okay with that. But whenever it's both of those together, we've got to do something. That's where that 1 out of 10 comes from. On a side note, I've got a testimonial on the wall back there of a lady that we saw about a year ago. And she came in, she had three of the 4 muscles of the rotator cuff were completely torn, completely detached. Horrible, especially on imaging, looked terrible. Realistically, there wasn't a whole lot we could do according to that imaging, but we applied this method. We applied this approach of looking at all the pieces and dealt with the pain, number 1, and tried to get that pain inflammation down. And then we started working on, when that came down significantly, putting her through a vigorous approach to using different muscles to get that motion back. Now she is in her early 80s, so she's able to get to about right here. Now, I'm in my early 50s. I don't have to do this. I do have to do this to get into the cabinets and things like that. So her motion is functional and her pain is minimal to non-existent. Now hers is a rare case, but she physiologically has a completely blown shoulder, but she can do what she needs to do. So there are signs whenever we do have that imaging, and we'll talk about that just because it says it's gone doesn't mean that's the end of the story. So that's what things look like with this approach. So again, we talk about reproducible. If the pain is reproducible, there is hope. If we can find out what it is, we can elicit that change. And if we can reproduce it, then we can reduce it. And that's the whole goal. somewhere around here. I don't know where it's at. We look at 3 phases of healing. So, and it doesn't matter if it's the knee, the shoulder, if it's a new thing, if it's an old thing. 3 phases of healing. Number 1, we need to knock pain and inflammation down. If we can do that, that's the biggest struggle to get through all of the issues that we might deal with throughout the body. Pain and inflammation. Second piece, this is a machine that's designed to work within certain tolerances. So the shoulder, again, a little bit more complex because it's got 6 degrees of movement, 6 planes of movement. But we have to get each of the body systems moving in the direction, within the tolerances that they're designed. At 82, we've got a little bit more give there than we do at 22. 22, the body's going to be doing a whole lot more than at 82. But if we can, again, if we can reproduce it, then we can reduce it. So the second piece, healing. The second phase of healing is restoring motion, mechanics, and strength. And then the third piece is just getting back to life. If we can do step 1 and step 2, it's just then about re-engaging. And then occasionally fine-tuning when things are going on. If we have some tears, if we have some degeneration, we are going to have to maintain whatever's happening. I try to remember every morning to do my exercises. So I've got the shoulder stuff, but I've also got neck and back stuff. So and my back stuff is more of an issue. I try to remember to be diligent to do my exercises every morning. I probably get it done 4 out of 7 days. If I will do them and I've drilled them down to about 5 minutes worth of work, then I don't have any problems. If I forget to do them for 2 or 3 days and I act like I'm 18 again, then it's going to sneak up and it's going to hit me again. So a big piece on the final step is definitely going through the exercises, the stretches, the strengthening to maintain this system working how it should. All right, so back on that worksheet, and Kat said we're not grading it. We're absolutely grading it. Anyway, if your pain, numbness, or tingling is reproducible, so even with the shoulder, sometimes we can get that tingling, and we'll talk about why in just a second. But if it's reproducible, if we can elicit that, then it's reducible. The second one, so here in the past 30 days, the worst pain I've had was, and for me, is about 2 out of 10. It hasn't been that bad. I'm actually on a really good string of no shoulder issues, so I'm really happy about that. And for me, I have pain when for me, it's sleep, or mine is heavy working overhead. For you, it might be reaching overhead. It might be lifting. A lot of people getting milk or tea or something heavy out of the refrigerator. That weight sitting out here creates a lot of force through the shoulder. So that's the problem for some people. For men, I had a gentleman before I came back over here. His biggest issue right here is just getting that hand in the back pocket. For ladies, this is a tough one. And loss of that is very critical functionally. Fixing your hair, or for some people, just getting up from the floor. And again, if there is a cause and if we can elicit a change, if we can reproduce it, there's hope, because if we can elicit that change, we can hit that first level of healing, which is killing the inflammation and the pain. So I think periodically about taking this out of this presentation, but it serves a really good point. 3 things to do when faced with a problem, and this can be any problem. It can be a marital problem, it can be a shoulder problem, it can be a kid problem. First thing we can do is we can ignore it. I'm going to use the analogy of a pothole. So I used to live on the west side of town over here. Finally moved out a little bit. But on the west side of town, we had a road that had a sharp incline, and the potholes, we lived there for 7 years, and the potholes there were horrible. The city never would come down there and take care of that for us. So they ignored it, and my analogy here is with shoulder pain. We can ignore that shoulder pain. It's going to go through phases. Every now and then, it'll just go away. If you've dealt with it long enough that you paid attention to the Facebook thing and you're here, it didn't go away. So we know something's still happening. So we can ignore it, number 1. Number two, we can alter it. So with the pothole analogy, we can come back and we can fill the potholes in with some asphalt. So about a month before we moved, they did finally come and fill the potholes in. And I say that, there was about 6 of them. There was one, I mean, this was a big thing, and there were about 5 others, smaller ones around it. Well, they came in and they patched the smaller ones, but they didn't patch the big one. So and that lasted about a week, first rain, and it was all over again. So we can alter that, but it doesn't really solve the problem. In the case of the shoulder, what that represents is drugs, injections, or surgery. So anytime we're dealing with, again, whether it's a shoulder, a neck, a hip, a knee, if there's some dysfunction in that movement system, then what it really means is that the normal mechanics, and I'll use the knee as an example. The knee straightens and bends. That's all it does. If the knee isn't straightening out all the way, then we've got a mechanical problem. In the shoulder, we've got a lot more things that can be going wrong. And so if we take drugs to knock that pain down, fantastic, and we can do that. Now, people ask me all the time, well, you don't believe in drugs. Well, that's not necessarily true. I don't believe in taking drugs for years on end to manage a problem, because that's just covering it up and that's not taking care of it. Injections, same thing. We can get the injection and it can knock it down, but if it's been going on long enough, it's going to still be a long-term problem. And so something's going to happen. We have to get the thing moving how it's designed. Similar with surgery. And I've got a lot of orthopedic surgeon friends. Every one of them would want to avoid surgery if they could. Nobody wants to have surgery, especially shoulders, if you don't have to. So again, if we have, especially if it's wear and tear, degenerative process with the shoulder, then what we see happening is, again, a change in the normal mechanical function of that system. And so you can go in and you can have surgery, but you still got to do the work on the other side, because we have to get it moving correctly. Just tying that muscle back together doesn't change the fact that the system is out of whack. So surgery is really just altering it. Again, even in the case where it's a complete rupture, there are times where we can fully recover from that. So what is the final answer for it? Is we handle it. So we ignored it, then we tried altering it, and then ultimately we're going to handle it. So here, the only way to handle that road over there is for them to repave it. Unfortunately, I left before they repaved the road, so I didn't get to see the final product of this analogy. For the shoulder, what does that mean? Learning to get either natural treatment and then learning mainly to manage your own symptoms. That's the critical part. We can deal with phase number 1. We can help knock down the pain, knock down the inflammation. But the real key is I'm more interested in you being able to manage this shoulder issue 5-10 years from now. So before we finish, I'm going to show you a few things that you can do. And these are things that I do. These are things that I have my patients work on. And normally I'll have them work on even before, so somebody comes to this workshop, I'll normally have them work on those things even before we consider doing actual hands-on work. So we'll get into those things. So to the worksheet, I think this one and one more time on this. Number 1 single biggest mistake shoulder pain sufferers make is they ignore it. And then 3 things that you can do about your rotator cuff and shoulder pain right now is you can ignore it, you can alter it, or you can handle it. Again, it takes a little to sign up, to call in, to come in to this little workshop. I'm not the most entertaining person out there, so kudos for sitting through this. So we know something's going on. So you've done at least the initial part of trying to handle it. And hopefully you'll leave here with some stuff that'll help. Okay, 3 main causes of shoulder pain. Is that you yet?
I think so.
I think I've got 2 more. Okay, yes, let me go over imaging.
Okay, go ahead.
And then you're up. So a quick discussion of imaging and what does normal look like. So I am not against imaging. I love to look at imaging. but I'm not gonna base what I do on imaging. Let me explain why. So here's an x-ray of a relatively normal looking shoulder. Kat talked about the upper arm bone, the humerus, about the collarbone or the clavicle coming over here, the acromion that sits right out here, and then you can make out the scapula, the shoulder blade right back here. Honestly, this shoulder looks about like it should. There's nice space in between the ball and the socket. I don't see, that looks like a spur, but that's not a spur. There's a ligament that attaches right there. I don't see any spurs coming down anywhere. Nothing's terrible. He may have a little arthritis right up top there, but nothing terrible. So one would normally think, well, this person is fine, what they have an x-ray for? It is very common for us to see people with horrible shoulder pain, 7, 8, 9 out of 10, and their imaging looks fine. And the reason is x-rays are gonna show, or even MRIs, they're gonna show the structures and they're gonna show what may be present as far as any sort of abnormalities or any pathology, but what they don't show is pain, because a picture can't show pain. Now, if that bone is snapped in half, that's pain. But our normal wear and tear issues that we see and soft tissue injury, some of it can show up, but it doesn't identify where the problem is. This person with horrible pain could have more of an issue in the neck, radiating out there. Which brings me to my next slide. Oh, let's talk about some studies. I won't bore you with much of this, but to illustrate a point of imaging, an MRI study of adults who have no shoulder pain show that 20% have partial rotator cuffs and 15% have full thickness tears. In addition, in those 60 years of age and older, over half had no shoulder pain at all, but they had rotator cuff tears on their MRI and they didn't even know about it. So over the age of 60, we've got half the people in this group walking around with pathology in here, yet they're functioning, they're doing fine. Another study on professional baseball pitchers, 40% of them had either partial or full thickness rotator cuff tears, yet had no pain while playing and remained pain-free for even after 5 years of the study. So the take-home message here, do not panic if your imaging shows a rotator cuff tear. It shows some pathology, but it doesn't tell you where the pain is. So again, I love looking at the pictures, but the pictures and the pain don't always coincide. Which brings me to the vomit and the barf. Vomit and barf. Vomit is being a victim of modern imaging technology and the brainless application of radiologic findings. And what that means is it's treatment based on imaging findings alone without any clinical correlation. So we talked about that picture of the shoulder earlier, and that person could have 8 out of 10 pain. We look at, so picture of a knee here. In the knee, just a sidebar, what we're looking for is to make sure we have some decent space on both sides of the knee. You can see on the inside of the knee, looks really good, gets really close out here. But this person can have this image and not have any problems at all. So we have to be careful on trying to go in and fix every little abnormality that we see in the body, because it may not be causing a problem. All right, the 3 main causes of shoulder pain, and I will turn it back over to Kat.
Okay.
Now I'm going to say there's a lot of causes for shoulder pain. We've really tried to collapse a lot into 3 primary categories.
All right, so he's already touched on some of this, but neck problems obviously can definitely contribute. Okay, good. Here's all the little pictures we have. So there are several things you can see. I think you talked about some of this showing up, that can show up on the imaging as well. You can have some stenosis, which is kind of just a fancy word for like a narrowing. Stenosis, yeah, so narrowing here is important just because you have nerves basically that travel through those little holes in the bone. So if you have any kind of narrowing, which can be due to multiple causes, whether it be disc, whether it be bone spur, either way you're taking up space where that nerve is trying to come out. And if you approximate or if you get close to a nerve or pinch on it, that's when you can start getting symptoms that radiate down. So just like he was saying, you can have pain that comes here or all the way down, but that doesn't mean that the problem is here. A lot of the times it's actually coming from the neck. So that's why we have to be careful to screen and make sure you don't have cervical issues that are kind of feeding shoulder pain. So we have a little picture here where you can see how the bone spurs could potentially impact those little nerves. With stenosis, you start losing height, and we just discussed how any kind of nerve compression can give you the pain that's referred elsewhere. So there's that. Okay, also, yes, so the rib cage and the first rib. Was this one in regards to TOS or just lucky guess? Okay, so looking at this, so TOS is thoracic outlet syndrome. And so these little yellow guys coming down, that's basically a nerve bundle that exits out of your spine, your cervical spine up here. So you can see it comes from multiple levels, but they all travel through this little path. So basically this little tunnel right here where they're kind of running through the neck out to the shoulder, that's called the thoracic outlet. There are several areas where you can have impingement. There are three main ones, but right here we're kind of looking at the first rib. So if you have compression at this point, which can be due to multiple things, I've actually seen people too, it's interesting, you can either be born with like a congenital anomaly or like a difference, like you can be born with an extra first rib up there, so obviously that would cause some compression, or if you shift either of these guys, you know, whether it be due to trauma or some kind of change due from repetitive, you know, overhead or job-related activities, basically if you shift that, you can potentially get compression of that nerve bundle there. So similarly to, you know, issues kind of further up in the spine, if you get compression right at that point, you may be saying I have shoulder pain, but it really could be compression right there at that point due to the first rib. So that's talking about thoracic outlet syndrome. What else? Okay, and then in general, we're also just considering limited range of motion in the neck. So your cervical spine can also get a little fancy and complicated, but the basic motions are going to be flexion and extension, so that's just up and down. So flexion is bending down, extension is up. Rotation obviously is just the turning of the head, and then side bending is like taking your ear to your shoulder. And if you're limited in any of these areas, that can contribute to shoulder pain as well, because you also have to think about too the muscles that connect from the shoulder to the neck. So like we discussed earlier, if you have limitation in one area, you're probably getting, you know, limitation or pain, you're probably getting a guarding of those muscles, and that's going to in turn affect the surrounding joints as far as limitation. So again, with the shoulder, it's just really important to find out what's contributing to the issue, and a lot of the times it's not one thing, it's multiple, so just take some searching. What else? Okay, and then here we're talking about impingement. I feel like that's a super thrown around term, but you can actually get really specific with classifying impingement in regards to the shoulder. I would say, yeah, it's definitely one of the main causes of shoulder pain, but they're classified on different types. So you have, let me just run through this. So you have primary impingement, secondary impingement, and then you also have what's called internal impingement. You don't need to worry about all the words. But just know that there are several places basically where you can get a pinching, whether it be, you know, muscles or what have you in the area. A lot of the times it's with elevation or bringing up, and there are certain signs you can see in regards to like each classification. So for example, like primary, that's usually one where it's degenerative and you kind of accumulate it over time. This may be someone upwards, not all the time, but a lot of the times it's like 40s, 50s upwards from repetitive movement. So let's say someone worked on ceilings for a really long time or on cars or something like that. A lot of the times that repetitive motion can just cause this cumulative fraying. So like that little highlighted one there, as you can see, it kind of runs out under the scapula, and every time you're lifting that arm up, you're kind of fraying and pinching. So if you do that for a couple decades, I mean, it kind of catches up to you, unfortunately. So that would be primary versus, you can look at secondary or the others. You can also have impingement related to, a lot of the times with like throwing athletes, you can even get a pinching just of the cuff on the back. So all that to say, there are several types of impingement. That's kind of a general term, but if you come in and kind of collect your history and chat with you, we can typically figure out what's going on. So a little complicated, but yeah, impingement is definitely one of the main causes there. Look at that, more answers. So Yeah, a lot of the times, hallmark signs with impingement, one would be trouble reaching behind the back, and kind of like Luke was saying, side sleeping or on a raised arm. I know you can't help it all the time, but if you can, try not to do that. And essentially, impingement in general, that's just talking about that space right in there getting smaller, and then so that can be correlated with bone spurs, which will lead to fraying that tendon, and then that can lead to a tear. So that's kind of the general spiel. Let's see.
I think we have a question.
Someone say something? Hey.
Hey, what's frozen shoulder?
Okay, so you wanna take this?
You're doing a great job.
Great. Okay, so frozen shoulder, I would say it's almost like a syndrome. It's basically a collection of symptoms, and usually the hallmark of that is what we call a capsular pattern, or it's a pattern of movements that are limited in the shoulder. Frozen shoulder is really interesting just because sometimes it's idiopathic, meaning there is literally no explanation for it. The general demographic or people who are affected by this, it's usually women, not all the time, but usually it's women anywhere like 40 to 60-ish. So that can be due to no known cause, which stinks because there's no rhyme or reason. But a lot of the times you also see it associated with some kind of trauma, or let's say someone had like a rotator cuff repair and they didn't get it moving well enough for whatever reason. The shoulder can be frozen, so to speak. And so that's just very marked limitation as far as movement and pain. And there's usually really distinctive phases of frozen shoulder as well. So the first phase is called, unfortunately, the painful phase. But basically, almost any movement of that thing is just horribly painful. And that can run, anywhere from weeks to months. And then when that is up, it kind of shifts to the stiffness phase, to where they may still be limited to here, but it's not because it's painful, it's because it's just really, really stiff. And then that's where we can kind of start pushing it more as far as what we see here in the clinic.
So you treat that?
Oh yeah, all day, every day, yeah. But yes, sorry if that was a little long-winded, but it's basically just a collection of symptoms. The main thing being just, like a really notable lack of mobility, either due to no reason or related to trauma. So, that's it. Does anybody else have questions? Okay. Yeah, I'm pressing this.
Yeah, go ahead and press that. So this is a little video that I put together. It kind of talks about impingement. It takes a second to move.
Can I click it?
Yeah, go ahead and click it.
It'll work.
Okay, here we go.
Whoa, look at that.
So this impingement, I'm going to steal that from you.
Zero button.
Happens right, where did we go? Right out here where this upper rotator cuff muscle, again, it attaches onto the humerus upper arm bone. It goes underneath that acromion. So you can tell, and it's going to turn here in a second, you can tell there's not a lot of space. There's less than 1 centimeter of space between that upper bone and the upper part of the upper arm bone. And so if we've got some irritation in this muscle, well, what happens when something gets irritated and inflamed? It swells. So we've got less than 1 centimeter already, and as you can tell, there's not a lot of space right there. And what you don't even see here is there's also a couple of bursts that sit right there. So if they're inflamed, then they're swollen. So what happens is all of a sudden, this whole thing just really doesn't move that well anymore. First time a person comes in, normally we ask them to raise their arm, and they give us one of these things. And that's because it's so, the space in there is so occupied that you just can't move it much. And you mentioned frozen shoulder. A lot of times it can be idiopathic. Sometimes we have no idea why it happens. A lot of times it's because of this impingement. It happens, we've spent our time not moving it very well, and before you know it, that capsule around that ball and socket joint have gotten so restricted and so tight that it just can't move. And so, yeah, just a little illustration there of that impingement piece. I like my videos. Sorry. Down here, don't need to watch it again. And I don't even know where my mouse went. There it
Oh,
is.
down there.
Okay.
Cool. Yeah, so another thing we'll address posture.
Can we
And
do
try
this
to
one?
I can try to do your little exercise thing. I think I
Go for
remember
it.
correctly.
Go for it.
Correct me if I'm wrong. Okay, so just a little exercise here. I want everyone to kind of, unless you already are, you can go ahead and slump forward into horrible posture. And then pick a shoulder. If one is hurting, you don't have to try and move that one. You can try the other. If both, then good luck. But you can try and basically pick up as high as you can. Okay, yeah, it's not too hot. And then go ahead and stand up, or not stand up, but sit up as straight as you can. And then I want you to try to do the same exact thing. Is there any difference there to anybody?
Yes.
Yes, correct answer. It's been graded. So, yeah. So that was just kind of a little exercise on how, I mean, obviously those things are very intimately connected. So if you tend to have this hunched over posture, you're almost always going to have limited shoulder motion. So we usually have to address that too in conjunction with everything else going on. Did I do that right?
Yep.
Oh, yep, we did that. What else? Okay, this might be on that sheet.
Yep, should be.
Okay, so top 3 common causes of shoulder pain. A can be a neck problem. So we talked about multiple things there, but just know it can also come from the neck. Impingement, again, can be multiple types, but ultimately something's getting pinched on there. We're losing some space. And then C is going to be posture. So yeah.
Should we be? Arm.
Yep.
Okay, so, what does successful natural treatment look like? Before we do that, I want to show you a few things that I show every person that comes in, almost every person that comes in, things that they can do for their own shoulders. My right is more limited than my left, and so I have 3 things that without fail can help a little bit. There are a lot more that can be done, but I keep it simple with 3. One of them you may not be able to do if you've got some real shoulder issues, in which case do the other 2. So the first one I do is what I call the Peter Pan. So with shoulder pain, we either have a very strong amount on the front side, or we have some that's running right here, or we get this stuff back here. This is the one back here is what I like to call our overuse muscle. So we're doing a lot of work, you get a lot of pain on the backside. This first exercise is specifically for the muscle back here. And so we do the Peter Pan. And so what does Peter Pan do? He gets up here and he takes this thing. So what I'm gonna do is I'm gonna get this posture, and then what I really wanna do is try to roll. If you remember the Olympics, watching Michael Phelps swim, he warmed up by flapping his shoulders back and forth. Well, he can almost touch his elbows up here. I cannot. But I want to try to stretch this forward. When I do a stretch, everybody's got their own rule about how to stretch. Mine personally, that I use for me and that I advocate for people. I don't think there's a right or wrong way. But I hold my stretches for 3 to 5 seconds, and I do it 3 to 5 times. And only do one set of that. I like to do it, again, when I remember to do my stuff, I try to do it in the morning. Ideally, I should do it at night as well, but I usually forget. So I'm gonna do it 3 to 5 times. I'm just gonna come forward and put a stretch in there. Now, I don't know if you can tell, my right one doesn't come near as far forward as my left one. And that's because I still have some issues I deal with here. Pain is not one of them today. So I'll hold it a few seconds and then I'll let it off. So humor me, everybody try that. And just look and see what your elbows look like. Coming forward. You can do it sitting down. Sometimes you have to stand up to clear your hips. And doing that, so those hands right on the bony part of our hip, of our upper leg bone, I put my hands there and then I'll roll forward. And you should feel a nice little stretch back there. For a lot of people, that's a big part of the problem, is just muscle tension in that muscle. So that's one. I do it 3 to 5 seconds, and I hold it 3 to 5 seconds, I do it 3 to 5 times. The second one is for the muscle that we have our strains on more than anything, and that's the muscle on top. This one is a little bit more complicated. If your pain is up really high, you may not be able to do this one. So this one, and I'm working on my left shoulder. I'm gonna put my hand right on my belt line. I'm gonna grab, I'm gonna try to pull it this way, as far as I can, and then I'm gonna lean my neck and my body the other way. On this one, it's important, we don't want this shoulder up here. Part of the reason I'm leaning away is to try to keep this down, but that'll put a nice little stretch on this muscle up top. Again, as Kat mentioned, this is the one, if there's tearing, if there's pathology, 70% of the time, it's gonna be that one. So that's for that one. And thirdly, we talked about impingement, and as far as the shoulder, the impingement is the big thing as far as actual issues out here. For this one, I like to do what I call a lean. So any chair, again, I'm gonna pretend like it's my left shoulder. I'm gonna reach down, I'm gonna grab the seat. I'm gonna hold that rigidly, and I'm gonna let this relax. From here, because impingement is basically a loss of space in that area, I'm gonna lean this way, and I'm gonna drop that ball out of the socket a little bit. I'm not going crazy, I'm not leaning way over there, but I'm gonna give it just a little space to breathe. And so we take some pressure off of the muscle, off the bursa. We put a little stretch through that upper rotator cuff muscle. And if we're here, we go ahead and put a little neck on it. We get a little upper trap into it as well. Again, I do this 3 to 5 seconds, and I'll do it 3 to 5 times. Kat mentioned something about thoracic outlet. A lot of times when these nerves come out of the neck, underneath the collarbone, over the first rib, that can help put a little stretch on that. So that can help relieve that a little bit too. But for shoulder issues, these are always my 3 go-to things. Go work on these things. Do them every day. And give it a couple weeks, see if that improves what's happening. If it's just a neuromuscular tension problem, that may be a tool that you can use from here on out to really manage this stuff. I do mine whenever I remember to help with that. And I just keep it to those 3 things. Obviously, there's a lot of other potential pathologies, but those are nice little tools that can be helpful. So, what does natural, successful treatment look like? Number one, when we're in the initial pain stage, dealing with inflammation, dealing with elevated pain, we have, well, even in the next step too, for good treatment, we've got to put our hands on. We've got to move that shoulder. Mentioned adhesive capsulitis or frozen shoulder. It takes some force, it takes some pressure and movement of that capsule to get it to start stretching out. It's that capsule that's usually more limited than even the muscles. The muscles hurt when they're really tight, but it's that capsule more often than not that limits our motion. That's usually what's keeping us from here if it's not impingement. So have to put our hands on and move that. We go through lots of training, lots of and in fact, we practice and have additional training here fairly frequently on the best ways to do that. There are times we do it in almost a chiropractic approach. We're trained in adjustments, manipulations. There are times when that's appropriate. It's usually a short-term thing. It's not the answer, but it can help. It can be a tool that can help drop that pain down. So hands-on, definitely have to do that. Otherwise, you don't get past that first phase. You've got to get past the pain and the inflammation. So the hands-on, number one. Number two, the stretching and the strengthening. And I showed you the 3 stretching pieces that really kind of sums up a lot of things with a very short amount of stuff. And stretching is very important for decreasing muscle tension, but it's no substitute for getting the strength back. Rotator cuff is designed, its main one job is to hold the ball in the socket. Again, this little bit right here, it's going to do some of that, it's going to do some of the rotation, but a lot of the actual movement happens in other muscles. So it has to hold that ball on that golf tee, otherwise it's going to sit to the front, to the back, too high, too low, in which case then it doesn't work like it's designed to. So the strengthening of the rotator cuff, incredibly important. Finally, we talk about dry needling or a class 4 laser to break the pain cycle. If a person, and I use the number of 5 out of 10. If a person is below 5 out of 10, pain, everybody's pain numbers are different. If it's below a 5 out of 10, maybe the pain isn't terrible and you can move into the strengthening part. Or you can do some self-stretching at home. So that's really where I have people starting with those 3 things initially. But when pain is, say, a 5 out of 10 or higher, I don't care how tough a person is, you can't be tough enough to push through that type of pain. And the reason for that is the body's gonna respond and do more of this muscle clenching, more of this tightening around there. So at that point, you push too hard, then you're at risk of ripping and tearing and damaging. So when pain is that high, the dry needling and the class 4 laser do a great job of breaking that pain cycle. The short version on both of those things is they're designed, they operate differently. The laser operates at the molecular level. Dry needling, I'm gonna be honest, we still don't completely know how dry needling works. I've been doing it a long time, and I teach it. And when I teach my students, I still tell them it could be this, it could be that, it could be the other. But really and truly, we don't completely know. What I do know is when there is specific pain in specific muscles, rotator cuff, capsule, ligaments, tendons, we can needle into those without medication and elicit a healing response from the body's immune system. When that happens, we reset the healing cycle. And normally people are incredibly amazed with how fast that happens. Again, first step, knock pain down. So we use the dry needling or a class 4 laser. Some people are really phobic of needles. Understand, I was the first time I did it. In which case, the high-powered laser can really, I don't think it does quite a good a job, but for people who are phobic of needles, it can be a nice substitute. So killing that pain cycle is that part. So what to do next? Y'all have been so gracious and listened to me ramble and Kat telling her stuff. We need to do something. So again, I mentioned 5 out of 10. If your pain is at a 5 out of 10, you've identified it, you've decided to handle it, honestly, we need to do something about it. 5 out of 10 is way too high to be living with shoulder pain on an ongoing basis. Here, honestly, let's schedule you, let's get you in, let's look at it and see what's going on. Let's get a plan in place. If your pain is less than a 5, say it's a 2 or a 3, at some point we can do a free screen. You can come in and we'll take a look and see what's happening. We'll talk about what that looks like. And if you're at a 2 or 3, go home, start working on these things. Do your Peter Pan, do your little stretch across, do the little chair lean. See if that'll get some improvement. Odds are it will. The question is, will it get it far enough? And that's what we'll find out. So, my offer, again, you're gonna be dark soon. You're brave to come out and listen to me talk. I didn't even have any donuts or anything. So, I'm offering a free consultation. If you've got some issues going on, I don't know who else left up there. I know Ashton's there. Casey may be up there. We can schedule at your convenience a time to come in. We'll do it for free. We can talk to you, look at the shoulder, see what's going on. You know, Kat mentioned the shoulder is incredibly complex, and it is. But the system that we have in place to take care of these things, we've got drilled down pretty well to be able to tell you pretty fast if this is salvageable or if you're the 1 in 10 who needs to have the other stuff. So we'll look at the certain movements, feel it, to see if we can figure out what's going on with it, see if there's something we can do to heal it naturally. Again, give you some tips. You've got those 3 things. We'll look at some other things that might be specific to your shoulder problem. There's the glare. Oh, at the end, if you decide you want our help, fantastic. If you don't want to, that's perfect. We're not trying to sell you on anything, except that it doesn't have to be surgery. There are things that can happen that don't involve that. Again, the goal is to give you information, what's going on, what you can do to handle it. So I mentioned an evaluation and a consultation. Biggest difference is the time. With a full PT evaluation, I'm going to take, me, Kat, Liz, another great physical therapist here. We go through our regimented evaluation process to find out what's going on, what we can do about it. On the eval, we'll go ahead, identify it, and then if pain is elevated, then we're going to talk about the laser, the needling, whatever it is to break that pain cycle. We've got to do that. And then we're going to set up a plan of care to get you moving down the road. If pain is elevated, there's usually no shortcuts. It usually takes a commitment of time. Most people get through this in about 4 weeks. If your pain is low, then this usually can go pretty quickly. And most of it, if pain is low, we can show you what to do and you can move on almost self-paced. Free consultation, we're not gonna take as much time. We're gonna show you what you can do and you're gonna go do it and you're gonna do it a couple of weeks and you're gonna let us know if it's helped or if it's not, if we need to do something else.
What is your thoughts if injections take away your pain and they come back? And then how many injections can you go? You can go injections for the rest of your life if you're willing to sacrifice the cartilage, the muscle, and the ligaments. Because there is some arbitrary time where it does start to break those things down. My personal thing, so when I was dealing with mine, I got one injection, it didn't do anything. Unfortunately, I didn't know then what I know now, so I went straight to surgery. There are some people who their situation is such that they are, let's say they're a 1 in 10. I mean, they need surgery. But say they've got a cardiac issue, they've got a pulmonary, for some reason they just can't have surgery. In that case, I want the pain gone, so I'm gonna do what I need to there. But short of that circumstance, I would do it once, twice at most, and then I want something else. And that's what I do with mine. So. Do you believe that if you do that and you let years pass, it kicks up and you let years pass, that eventually the ligaments that are torn or whatever's torn, they shrivel up to where they can't do surgery?
That's absolutely true. So there is a degree of separation, especially on a muscle that's been completely torn in two. There's a point at which they just can't pull it far enough. And if they do, the potential for success goes way down. And we see that fairly frequently. That a good surgeon will look at it and just say, there's nothing we can do about it. And it has, and especially if the muscle has gotten really small. The upshot is, again, we're dealing with pain and a loss of function. If in that situation we have pain in that area, still our first goal is to knock pain and inflammation down. Tendons and ligaments don't really have nerve receptors in them, so if there's a tear there, it's the tissue around there that hurts. So that's what's unique about how we approach this, is I want to go find the tissue that's painful, and usually it's muscle. The muscle is the part that's usually giving us the pain. If we even with torn muscle, torn ligament, if we can knock that pain down, we can still restore movement. Keep pain down and get movement back, and that's our goal, is to get that done. Where am I here? Oh. Yeah, we're normally much more crafty with our audio-visual stuff. So anyway, I don't know if I've got 10 slots, or I don't know what my numbers are. But I know we can make time for a free consultation, a free screen, or for physical therapy evaluation. Again, if you're sitting with a 5/10, you've gone through injections, you're hitting ibuprofen every day, it may be time to look at it a little bit differently. And so we'd be glad to look at that. And so, again, 5 out of 10, we ought to evaluate and see what's going on. If it's lower, let's screen it. Let's see if there's anything we need to do. Yes, ma'am.
Would you like a testimonial on the dry needle?
Absolutely.
Well, I'll be coming tomorrow at 10 for my 3rd dry needle treatment, and I can tell you honestly, it has diminished my pain. Even as I was walking out the door, I reached down to pick up my purse, which I normally couldn't have done, and I got down and got it, and I said, oh my gosh, I can bend over. So, it's worked on me.
If I had been dry needling as a therapist when my shoulder went out, I would not have had surgery, because I can take care of the pain. And if we take care of the pain, we can restore motion. Then a lot of times that tearing, with a tear, the fibers of the muscle can either regenerate, or if it's big enough, they'll just scar over, as long as we get that inflammation down. In the case where they're just, that was done. But I've also seen people overcome it.
Yeah, but it's.
Thank you. Anybody else?
When would that be?
All right. Well, again, I didn't bring donuts, so I can't help you there. But if y'all want to schedule a free screen or evaluation, be glad to do that. They'll take care of whatever we need there. And appreciate y'all coming out. Absolutely.